Good evening, everyone, and welcome to the Together We Build Outpatient Services virtual town hall. This is the second in a series of conversations that will take place over the next few weeks, looking at 11 program-specific areas of planning for the new Windsor-Essex Acute Care Hospital. Before we begin, let's respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Nisui, Ishkoden, Anishinaabe, the Three Fires Confederacy, Ojibwe, Ottawa, and Potawatomi. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation. So on behalf of the project management team overseeing stage 2 planning for the new hospital, we are pleased to welcome everyone joining us tonight via Zoom webinar. I'm Allison Johnson, Manager of Communications and Community Engagement for this project, and your moderator for tonight's conversation. Tonight, you will have the opportunity to meet some members of the user group designing the future outpatient service department at the new hospital and downtown. You'll learn about the work that they're doing. You'll have the opportunity to ask questions. Please note that the Q&A portion will take place at the end of tonight's presentation. You're welcome, though, to post any questions at any time. You can do this by clicking the Q&A button at the bottom of your screen and then typing in your question. We'll do our best to answer as many questions as possible tonight, but do note that the focus of this town hall is stage 2 planning of outpatient services. So this includes items related to the physical structure of the department, its layout, what other programs and services might be located nearby, design features and technologies. And to maintain the flow and focus of this conversation, please ensure your questions are related to this and to future stages of planning. Now, following tonight's conversation, we also invite you to visit our engagement platform at togetherwebuild.wrh.on.ca. And there you can ask further questions. You can take surveys related to different areas of programming throughout the hospital, including outpatient services, and share your idea. All right. So now I want to introduce you to our panel guests for tonight. Everyone, please welcome Rosemary Petrakis, VP of Surgery and Perioperative Services, Dr. Ian Mazzetti, Chief of Medicine, Jen Cameron, Director of Ambulatory Surgery, Denise St. Louis, Coordinator of the District Stroke Center. Lucy Brune is a partner with Agnew Peckham Healthcare Planning Consultants, and she's been working with the Outpatient Services Group. Dr. Andrew Petrakis is Director of Clinical Service Planning for the project, and Paul Landry is Project Director for the new Windsor-Essex Acute Care Hospital project. So thanks for everyone on the panel for being with us tonight. And now I'm going to hand things over to Paul, who's going to kick off tonight's conversation with a brief look at what's involved in stage 2 planning and the goal of tonight's conversation. Paul? Paul, you are on mute.
Thank you, Allison. Firstly, I would like to thank all of the community participants who have taken the time to join us for this virtual town hall meeting. We appreciate your participation, appreciate your questions and your input. I'd also like to say how honored and privileged that I feel to be a part of the planning of the new Windsor-Essex Acute Care Hospital. This first slide that I will have a few comments on, it really depicts the multiple stages. There are 5 stages in the planning and development of a new hospital project. As you all know, we are in stage 2, which consists of developing a functional program, the first sort of 6 months of the year that stage 2 will take for us to develop, followed by working with architects to develop block schematic drawings, and then a refresh updating of the cost estimate that will be based obviously on the block schematic drawings and the total amount of space. The functional program is a document that describes all of the services, the patient flow, the volumes, and very specifically, a very long list of space. thousands of rooms that comprise all of the departments that will be in the new hospital. We move then into stage 3 after that document is reviewed by the Ministry of Health and we're given the green light to move forward. And stage 3 then is working with the architects to develop more detailed drawings that are referred to as indicative schematic designs. And they will also then be preparing the procurement documents to take that design out to the marketplace and seek proposals from developers that will bring contractors and an additional design team to further the design into working drawings. Stage 4 is that procurement process when we go out to the marketplace to seek those proposals and the developer, contractor, and the design team. And stage 5 is the actual construction of the new hospital project that we have estimated will take approximately 4 years to construct. If all goes well between these stages and the ministry's review and the final approval by the Ministry of Health and Treasury Board, we would be putting the shovel in the ground, hopefully in the summer of 2026, and opening the doors of the new hospital in the summer of 2030. The next slide is just a further detailed breakdown of the stage that we are in now. We're in the functional program development phase, and you'll hear a lot more about that tonight from Lucy Brunn, who's the expert planner on board with the team from Agnew Peckham. We're approximately halfway through that process. We've had 2 rounds of meetings with 40 user groups, but we're still only halfway through the process. We have 2 more rounds of meetings. We've reviewed a first draft of the document, but there'll be another draft for the next round, and then the final draft will be able to review and sign off on at the beginning of June. We will be releasing an RFP for the planning, design, and conformity team, essentially the architects and engineers that we plan to onboard in June, that will take that functional program and develop with all of these user groups the block schematic drawings for the second half of the year. Should take us to approximately the end of October. And then the cost estimators that will be reviewing those block schematic drawings and the program in the latter part of the year, to then be able to put the entire package together for a submission to the Ministry of Health early in 2023. Back to you, Allison.
Thanks, Paul. And as Paul mentioned there are 40 user groups working on different areas of the project. So much work started happening at the beginning of this year, and it really has been exciting to see all the teams and start to have this conversation that the team at the hospital and really this community has been waiting a really long time to have. So we appreciate everyone being here with us tonight. And we do want to note that this is early in the journey. We want you to join us. We want to keep you up to date on all of the project areas throughout. But sometimes that means that there are more answers than questions at this part in the journey because we're still working out some of the details. So you may find that tonight, but we do plan on having another series of town halls. We'll meet you back here again in the fall. And at that point, we'll see where we've progressed from where we are now to where we are then, closer to the end of stage 2. And really what these conversations are about is finding out what matters to you. And we really do encourage you. I see Jennifer put the link in the chat for our engagement website to please share your ideas and input so that we can continue to share those with the teams throughout this journey. And I mentioned the 40 groups. Paul mentioned the 40 groups. Dr. Andrew Petrakis, as the clinical planning director, sits on many of these. I mean, he attends almost all of these meetings. There have been a lot of them this year. So I want to start with a question for you, Dr. Petrakis, about what we're talking about tonight. When we talk about outpatient services, what's included in that? And then how does the work that's being done at these groups fit into the bigger picture of planning for the new hospital project?
Thanks, Allison, and good evening, everyone. First of all, I just, on behalf of all the functional planning teams, I'd like to extend our thanks for your participation tonight, and we look forward to your comments and questions as we move forward in planning our new hospital. We really do appreciate your comments. In terms of Allison's question, first of all, I thought I'd just touch on outpatient services really encompass a wide variety of hospital-based resources that include emergency department, diagnostic imaging, cancer care, pediatrics, obstetrics, gynecology, but all of these particular groups will be covered in other town halls. I just wanted to give a broad overview initially. The things that we're going to be talking about tonight include the following outpatient services, and mostly they are medical surgical clinics. In terms of medical clinics, the medical clinics encompass things like patients receiving blood transfusions, receiving IV infusions, allergy testing, and minor medical procedures that internists or hospitalists will be carrying out in the various facilities. In terms of surgical clinics and minor surgical procedures done under local anesthetics, we have a variety of clinics: plastics, fracture clinic, neurosurgery, thoracic and vascular, as well as our breast assessment clinic that will include the Ontario Breast Screening Program. We will have minor procedures with sedation, and these will include endoscopy and bronchoscopy. And finally, we'll have, for those patients who are coming into the hospital for surgical procedures, our surgical pre-assessment clinic. In order to provide all of these services and provide them for the patients to have the best experience, the functional planning teams will be coordinating the decisions regarding optimal location for these clinics and ease of access to other hospital services.
Thanks, Dr. Petrakis. And now I want to bring Rosemary Petrakis into this conversation, clinical VP overseeing this area. And Rosemary, what's the team's vision for outpatient services when the new hospital opens, both downtown and at the new campus?
So the team's vision for the future for the medical surgical ambulatory clinic is to plan the physical space, giving patients a smooth and efficient experience throughout their entire process of the hospital visit. Remembering, as we've said, a portion of the ambulatory and outpatient surgical services, some will remain in the city's core. How many and which ones will be determined as part of this planning process.
Thanks, Rosemary. And now I want to bring Lucy into the conversation. And throughout this planning stage, the user groups are working closely with consultants from Agnew Peckham Healthcare Planning. And this team has been involved in many, many new hospital projects across the province and many of the latest and big hospitals in Ontario, including the Ottawa Hospital, South Niagara, and Humber River Hospital. So Lucy, I'm going to hand it over to you now. She's going to talk about the work being done in this group and some of the trends that her team is seeing in the area of outpatient services.
Thanks, Allison. Here we go. So I'm going to talk about the outpatient services, then the planning process that we're undertaking with the representatives from the hospital, including those that you see on the screen today. So as mentioned, there will be services at both the new hospital and the Willette campus. And as part of what we're going to be doing, we're going to be looking at patient flows, materials and staff flows, the workload and the staffing. And those are all what we call the major space determinants. But also what's really important is the adjacencies to other departments. So for example, the orthopedic and the fracture clinics must be near radiography because many of the patients have an X-ray, and so we want to make sure that we're minimizing the distances that patients have to walk. we will be developing a detailed space list, and as you can see on the top, what that looks like. So it's a very detailed document, and there's all sorts of numbers next to as part of the room numbers, and we document the room names and the subcomponents of each of the rooms, and then how big each of the rooms are. We're looking at the projections for not just the day of opening, but also 20 years out. So we're looking at using 2018-19 as the base year for the projections. So this was before COVID, so we aren't having that impacting our projections at all. And the methodology is basically the base years, then applying the population growth and aging, the demographic projections, but also any adjustments that need to be incorporated in there. And then, as Paul said, the architects use the space list to create the block schematic plans, and you'll see the level of detail at the bottom there. So what is a functional program? What goes into a document? So number one, it's what are the services that are provided? We look at the staff, the patients, and the materials flow because we have to make sure that the architects understand how to actually design the department and the key adjacencies within the department to reflect that flow. The workload is the current and projected visits, and then we work with the program representatives to identify what the room utilization assumptions will be to be able to project the number of rooms that are required. We also need to know what the current and projected staffing is, because the staff need workspace, they need a place to put their coats and boots, and a place to rest during their breaks. And section 6 of the document is called Planning and Design Requirements. So this is where we document the key adjacencies, the adjacencies to other departments. So for example, there may be residents of nursing homes or residents coming from other hospitals for specialized care. They'll be coming through an entrance that is separate from the main entrance or the emerge walk-in entrance or the emerge ambulance entrance. And so we need to document that entrance so that it's that there's short distances from that entrance to the clinic areas. And then we also document the organization or zones or pods, and we list every room and how many, how big do they need to be. And we typically organize it within zones or pods to help the architects understand the layouts that are required. So these are some of the key elements of contemporary ambulatory care planning. And there are a number of organizations across Canada that are only comprised of ambulatory care services. But in addition, of course, in acute hospitals, we have ambulatory care services or outpatient services. I use those two terms interchangeably. So first of all, about the organization of the treatment areas, we organize them in standardized pod design. So typically comprised of 9 standard exam rooms, 3 larger exam rooms, because of course there are going to be patients who need more accessibility, or they may be on stretchers, or they may be in a scooter. So they need somewhat larger rooms. We also incorporate what we call consultation rooms. So these are rooms that don't have an exam table on it. So those would be more suitable for patients who are coming for education sessions, or just to have a chat with one of the care providers, or it may be used for other purposes, like if there's clinical research occurring, that there could be interviews there. And they can also be used for your learners, because you have a very important education role. So we co-locate pods. so that over time and day to day and week to week, the specific exam rooms within those pods can be allocated to different services as required. And the allocation of rooms, of course, is based on the volumes or the numbers of visits. It's also extremely important that we consider infection prevention and control. So depending on the services, we would be incorporating airborne isolation rooms. And these are different than just enclosed rooms because they have an anteroom that helps to manage the airflow. Of course, all rooms would be enclosed, but we also have to balance that to efficiency. So for sure, there is a design now where there would be 3 walls around the patient, and in some cases also with the capacity to close that, that front one. Throughout the hospital, you'll see many more washrooms. So we typically program 1 washroom per 6 exam or treatment rooms. And of course, they are all accessible. So whenever we talk about room sizes, we talk about them being accessible. And then in terms of operational efficiency and flexibility, certainly the pod approach helps to achieve that flexibility. And we look at the number of exam rooms within a pod or a zone to reflect optimal staffing. We haven't gotten into all of the details of exactly where staff will chart, but some hospitals choose to have documentation within the examination rooms, but certainly there would be a team room with multiple workstations where staff can document and plan the various services for patients. And then, of course, waiting is co-located so that there's flexibility over time. And I have to answer, I still have a house phone, and so I have to answer that. And it's probably somebody looking for money or telling me that I haven't paid my taxes, which of course are not true. Yes, I think my husband keeps saying we should get rid of it. This is a good example of why we should. And finally, the most important factor in all of the planning that we're doing is that it has to be patient and family centered. So some of it is about processes, some of it is, of course, the space. And so one of the things that will be important is registration and being able to do that efficiently. Of course, you know, we can get our boarding pass on our phones now. It should be possible in the future to be able to register for your visit and not have to wait in line or go to a kiosk to do that. Or if you've forgotten to do it as you enter the building, there would be a kiosk near the clinic area, your clinic area, or somebody would be there to help you do that in person. There's privacy and confidentiality by having enclosed rooms. The rooms will be larger in order to ensure that there's accessibility, but also for families to be able to attend as required. I mentioned earlier that patients would be coming from other organizations, other hospitals or nursing homes. And so rather than having the patient wait in a hallway, we would have some designated spaces for them and to provide some privacy, but also for staff to be able to observe them. And then there's all the things that go into creating a pleasing environment, and things like lighting and art and the paint colors. And that's the kind of thing that the architects will be getting into in stage 3 level of planning, but certainly anything that we can do to document that, we're happy to do in the functional program. So your input is wonderful at all stages of the design process. I've included some schematics here to help illustrate what I mean by a pod or a module. So a module is typically, or some hospitals call it a pod, it's comprised of about 12 exam rooms and about 3 consult rooms. We talk, and then that would be immediately adjacent to another one to allow clinics that need more exam rooms to shift into the adjacent area. There's public circulation, so this is how you would access the space. There's patient waiting, there's reception and intake. And all of the spaces that you would see are typically called, just like at Disney, on stage. But then there's all the offstage areas as well that are essential for the staff to be able to do their work well. And this, for example, would be the area where somebody who's coming from a nursing home or another hospital would be entering offstage and then going into the clinic area. And then this schematic shows a little bit more detail, and it's just one example, and your architects will bring many examples, but the waiting area would be up at the front here. And then these are other rooms that are important to support the staff. And then this would be the team room, a place where they can document. Of course, there would have to be enclosures so that that privacy is ensured, and that patients in these other rooms couldn't hear the conversations that are occurring. And so that's the end of my presentation in terms of the kinds of things that are fairly standard now in outpatient or ambulatory planning. And there's been lots of examples recently in Ontario and in other provinces where really wonderful, flexible, and patient-centered outpatient services have been developed that can be used as examples.
Thanks, Lucy. And I really did appreciate that presentation. And I think for people who are joining us tonight, it may be difficult to really appreciate how different these standards are that you're showing us compared to what we have. And the one that really struck me was what did you refer to it as, the on and off Disney such a stage. Sometimes right now when patients are being transferred to the hospital from another location, at the Outlet campus, you're standing in the Tim Hortons line and they're coming past you. It's not a private entry. It's not ideal for the patients coming in, and it's not ideal for the individuals who are standing in line or on an elevator. So that really will, just that one little piece will make a big difference. So thank you. Thanks for that. For those who are playing a Zoom bingo with us tonight, we'll note that that was one muted mic and one landline phone call now that we have. And I do have some more questions for our panel guests, but I do want to remind anybody, if you have questions throughout tonight's conversation, please make sure that you put them in the Q&A section by clicking the button below your screen there, and we will get to them throughout at the end of tonight's conversation. My next question right now is for Dr. Ian Mazzetti. Dr. Mazzetti, what impact will the decisions that you're making today in the user groups, specifically related to outpatient services, have on the patients of the future once the new hospital opens?
Thanks, Allison. It's a great question. I'll preface my comments by quoting a famous philosopher who said that making predictions is difficult sometimes, especially when it's about the future. And I say it somewhat tongue-in-cheek because the amount of data gathering and preparation that has gone into this stage 2 process has really boggled my mind. I'm a simple clinician, and to look at the amount of sort of data dredging that's gone on, to look at population growth, estimated number of beds, number of visits that will be needed for 10, 20 years down the pipeline has really been staggering. The clinical excellence will remain, the compassionate care will remain, but I think, Lucy and Allison, you highlighted already the flow of the patient and their loved one, the experience of the patient moving through the system, I think leaves a lot to be desired currently. Even simple things. I'll give an example. In a pre-assessment clinic visit, if you have a loved one who's coming in for a big surgery, they would have seen their surgeon in the office, but they need to come into the hospital to be assessed by their doctor who will be doing the anesthetic. They'll need to be seen by the pharmacist to have their medications reconciled, the internal medicine specialist, potentially if they have a history of heart disease. And currently, the way things are set up is sometimes these visits are happening on different days. They're happening in different parts of the hospital. And so the way that we're currently setting up the geography of the new place is that it's going to be a one-stop shop, as we said. A very smooth run through from registration to consultation. Even simple things in planning of having a little cubby where the vital signs can be taken in a private way, where the person's weight and height can be taken. These are things that, our current setup, we haven't set up in a systematic way. So I think looking at the patient experience and how we can improve flow through the system is really going to have impacts down the line. And, who can tell what the next clinical advances will be in 10 years or 20 years. But, the team working on this, I have every confidence that we're going to be prepared for whatever healthcare is going to throw at us.
Thanks, Dr. Mazzetti. Next question is for Denise, coordinator for the District Stroke Center. How will the changes that we're talking about today impact the TIA stroke patients who come into the hospital?
So, building on, all that wonderful layout that Lucy showed us and the comments by Dr. Mazzetti about the flow, just being more specific, the TIA stroke prevention clinic is a specialized clinic. So just how this will affect that clinic. I mean, we do quick access to specialist consult, diagnostics, referrals, health education. And the fact that, we'll have proximity to diagnostic imaging, a designated space to accommodate family members, access to specialists right there, and conference education rooms for our patients where they can be private and we can provide them with things like multilingual resources and information and a format that is appropriate for them, patients with special communicative needs. It just sounds wonderful. It's my job in the past 10 years has been program planning and advocating, and now I'm being asked, what do you need? What do you need? It's wonderful. It's wonderful to be a part of it. I think it'll be great for our TIA and stroke patients.
It certainly is an exciting time, and you can hear that in Denise's voice. You can hear it in Dr. Mazzetti's voice. You really can hear it at all of the user group tables. Jennifer Cameron, a conversation that I had with you that I remember as well, where you said the decisions that we're making today will be our legacy for this community for generations to come, and that really struck with me. And so I want to ask you, how important is it for you to hear from patients throughout this process? And what types of feedback are we hoping to hear from them?
Thank you, Allison. And first of all, before I answer your question, I just really would like to thank all the community partners and friends who are joining us on the Zoom call tonight, because it is vitally important at this stage of our planning to hear the perspectives and the voices of the current patients, their families, the staff, the multidisciplinary team members, because your feedback will help guide us to the improvement in the design and the types of spaces and the rooms, the tools and the technologies that will be needed in the new hospital in the future. So thank you.
Thank you, Jennifer. And again, I do want to encourage everybody to visit our engagement site after tonight's town hall conversation, togetherwebuild.wrh.on.ca. You'll be able to actually see the town halls that maybe you weren't able to join. They'll be posted there after. You can also provide further input into outpatient services and the 10 other areas of planning for the new hospital that we have featured on that site. You'll have an opportunity to complete surveys, share your ideas. I've pulled up the outpatient services idea board right now, and there are some people who have posted their ideas. Again, last night and again tonight, we had an individual who's worked at another hospital and says, here are some things that you might want to consider in the area of outpatient services that I've seen at other hospitals. And we encourage you to do that. And you can comment on other people's comments and really get those conversations going. I do want to turn now, we do have a question in the Q&A here from Paul. Paul wants to know, What are the criteria used to determine which services are going to be offered at the OLET campus and which services will be offered at the new acute care hospital? And will there be services offered at both sites? And Rosemary, I'll direct that one to you, and maybe Lucy can jump in as well.
So I'll answer part B of the question, that yes, there will be services at both sites. There will be ambulatory and ambulatory procedure clinics at both sites. Lucy, how do we determine which goes where?
Well, it's a great question. And the process started actually in many years ago. The stage one started in 2013, that planning. And at that time, and closer to 2017, we met with the clinicians and we talked about, what are the criteria that are important. And of course, quality and safety were the number one criteria around ensuring that that if services were at the Willette site, that the quality could be as good as at the new hospital. Another related to the availability of clinicians. So if you only have 2 specialists and they're responsible for, and I'm just speaking hypothetically here, but if they have to be in the operating room, cover the emergency department, cover the inpatients, it's going to be very difficult to also ask them to provide services at another site. But if you had 20 specialists, that might be, feasible to do. The other considerations was not duplicating, no unnecessary duplication of expensive equipment or infrastructure. Another consideration was, is the service provided by a multidisciplinary team? And in that case, you couldn't split the team. You'd have to have the team available. And another criteria that's often used is around, the equipment. So there is a fair amount, and we're getting it more into, and my example is going to be imaging, but there's CT and radiography and ultrasound at the Willette site. It still has a useful life. So, for any outpatient services that may be at the Willette site, we also have to consider whether the necessary diagnostics will be there. And Dr. Petrakis mentioned breast health, so that's a great example of a clinic that also needs imaging services along with it. So I guess, in summary, there are many criteria that are considered, and there's, and I've touched on a few that certainly have been discussed over the years as we've been reviewing what services could be at the main, at the Willette, and at both.
Maybe just to add, Allison, to that, to Lucy's comments, certain services such as the Breast Health Assessment Center and the OBSP, the Ontario Breast Screening Program, were actually named within the ministry document or comments on our stage one submission that they thought should be at the Willette campus. So we have to build around what they expect, not to say that it can't or won't change in the future, but if we decide that we do want to make alterations, we have to have good reasons behind the change that we suggest. As well, in terms of small departments or small numbers of members in certain departments, there's been a great push recently over the past several years, realizing the new mega hospitals coming to enhance our recruitment. And this applies to every department. And I'm sure Dr. Mazzetti can comment on the great strides that the departments have made in starting their recruitment drives.
Yes, absolutely. Dr. Petrakis, what I'll say is, I came to Windsor probably 9 years ago then, and the idea of a new hospital was sort of vaguely on the horizon. There were the mists of time, but it's coming now. It's clear. It's in the future. It's in our you know, in our sites, and this has made it so easy to bring the highest quality talent. You know, I can speak for the Department of Medicine. You know, we've recruited rheumatologists, we're recruiting endocrinologists, we are fully staffed with interventional cardiology now after an aggressive recruitment period. And so really the new hospital has really helped us, you know, staff our department with excellent clinical folks. And, you know, Windsor, I tell anyone who will listen, from a recruitment perspective, this is the best place to live and work in Ontario, honestly. And this new build, working with our community to make this thing happen, I think only raises the stock. So it's a really exciting time.
Yeah. Especially in conjunction with the medical school and the programs of residency and family medicine. We've been able to expand our hospitalist program, which will certainly contribute to the new hospital as well.
And also, we need the space at both sites for research. There is a lot of research both on inpatients and outpatients, so we need to have the space and the accessibility for the researchers.
And these are all conversations that get me really excited when we start talking about what the future looks like, and then this excitement starts to build, right? And I've heard exactly what Dr. Mazzetti, what you said, when I talked to so many physicians, this was part of their decision when they came here, or they've been here for forever, and this is really an exciting time. And the energy that this new project brings is very welcome, and I hope it is in the community as well. And I suspect it is. A comment from Lori Allen. Lori says, I just want to say thank you for letting us add our comments and be part of this process. My mom has been an inpatient at both campuses as well as the CMC for the past 5 months, and she's been here pretty much every day and feels families have a lot to contribute from a patient perspective. And we absolutely agree. And that's what this is all about. So thank you, Lori. And thanks for everybody who's joined us tonight. I don't see any further questions. So, and I think that that's a very nice note there to end on. But again, I hope I don't sound like a broken record, but I do encourage everybody to visit our site and continue to share your questions and suggestions if we didn't get to all of them. This is not the end of the conversation. This is the start. And as I mentioned, we're going to take all of the comments and feedback that we get throughout these town halls right now. We're going to summarize them, and later this year, we'll share them with the planning teams and with our community and with anybody who comes on to the project as we move forward, so that they also know what our patients are expecting, what our community wants from this project. So please visit our site tomorrow. Same time, we're going to be back here to talk about pediatric services. You may see some of the same faces here, but we'll have some different conversation and answer your questions about that as well. So that's it from me tonight. On behalf of the project management team and everybody here, thank you. And I am going to give the final word tonight. We did rock, paper, scissors at the beginning, and Dr. Mazzetti won, and he gets to take us away tonight. Dr. Mazzetti?
Thank you, Allison. I will not be present tomorrow. You don't want me anywhere near pediatrics. I only deal with adults. But yeah, you know, great discussion tonight. You know, a wide range of topics. You know, we heard from Paul about sort of what stage 2 to 5 entails, so sort of setting us our map for the next few years. Dr. Petrakis took us through sort of the limits of this discussion in terms of the outpatient services, and we heard from Lucy. And Lucy, I got to tell you, I love those the schematics of the diagrams. I try to put myself. It's almost like a video game where you're navigating your way through the clinic. And so hearing all the group's questions, you know, learning about the community engagement, I think there's an excitement here. And, you know, as we say, I think there's 10 of these sessions where we're learning as much from our community. I think at least I am, as I'm learning from our colleagues who are on this call. And so it's a real team effort, and we're very excited to be moving forward with this. So thank you all for tuning in. Thank you to my colleagues and to Allison for helping organize this.
Thanks, Dr. Mazzetti. Thanks, everybody. And thanks, everyone who joined us. We'll see you tomorrow.
Tomorrow night.
Thanks, everyone.
Thanks,
Take
Allison. Bye.
care.
Night.
Bye.